Ladies and gentlemen, colleagues, first of all, I'd like to briefly introduce myself. My name is Michael Strupp. I'm Professor of Neurology and Clinical Neurophysiology at the Department of Neurology at the University of Munich and also the German Center for Vertigo and Balance Disorders. Over the last decades, I have published more than 460 PubMed-listed papers on vestibular, oculomotor and cerebellar disorders and 5 books. By heart, I'm a very passionate doctor. I love to see my patients on a daily basis, and I can tell you, although you are not an expert, you can easily diagnose most of your patients by taking a systematic patient history and also by an examination of the oculomotor and the vestibular system. And the app, which you are going to use from now on a daily basis, will be guiding you. Enjoy the use of the new app. So, ladies and gentlemen, colleagues, here you see the application of the app in a real patient. How long do the symptoms last?
Like 1 to 2 hours, I think, on average.
Do you have also shorter or longer lasting episodes?
Not more than a few hours.
Okay, so lasting hours. Good. Did you ever had symptoms which lasted longer than 24 hours?
No, that I can't remember.
Do the symptoms occur in episodes or is it a persisting problem?
It's in episodes.
In episodes, yes. Okay. The next question is, do the symptoms vary during daytime?
No, I don't think there's a pattern.
Good. When you rest, are the symptoms less severe?
Yes,
less severe.
definitely.
They're better. Okay. Good. Did you ever had any problems with hearing or tinnitus or fullness in the ear during such an episode? No. Ear pain?
No.
Blurred vision?
No.
During such an episode? No. Unsteadiness of gait, you already mentioned. Do you fall to one side during such an episode?
I don't think so.
Okay. Is your speech impaired?
No.
Not. Double vision?
No.
Okay. Impaired sensation or weakness of the arms or the legs?
No.
Okay. These questions are very important to discriminate whether, for instance, in a patient with acute vertigo, it's peripheral or central. And therefore it's good to have such a long list because often doctors are not aware of the relevance of these accompanying symptoms. Good. So I think we have now completed your patient history. Now we move on with the examination of eye movements and the head impulse test, as well as the diagnostic Simon maneuver and finally the Romberg test. So the first procedure is to look at a spontaneous nystagmus, and the app will tell the doctor how to precisely position the camera. And there will be some signals, so I now move the camera closer to your face. As soon as the system is happy, just look straight ahead. Now we look for a spontaneous nystagmus, namely for a horizontal torsional nystagmus as in vestibular neuritis, or for an upbeat or downbeat nystagmus, which would indicate a central lesion. Another important issue is whether the patient is able to suppress a nystagmus by visual fixation or not. Now you will fixating, and to reduce fixation, we will now apply the Frenzel's glasses, and the same can also be done with the Michael's glasses. And now you hear click, click. The camera is taking a video. Okay. So this was the examination for a spontaneous nystagmus. And the quality of the images is really good. And the camera gives you feedback whether the eyes are in focus and how the quality of the recording is. Okay, now we examine the patient for a gaze holding deficit. And the camera exactly tells me where to put my finger. Look at my finger. We will look upward. When I will look downward in a few moments, you have to lift your upper eyelids. Please do that. And now look at my finger here. Very good quality. I can clearly see your eyes. Now we look for horizontal gaze-evoked nystagmus. Keep your head straight ahead. Wonderful. Now look to the left and fixate my finger. Fixate my finger. Very good. I can sharply see your eyes. And the system will later analyze whether you have a gaze-evoked nystagmus or not. And now please look to the right. Very good quality. Okay, so that was a full examination of your gaze holding function. If you have too much alcohol, if you're treated with an anti-epileptic drug, or if you suffer from a cerebellar disease, there will be a gaze-evoked nystagmus, which will be diagnosed by the system. Okay, now I'll cover your left eye, right eye, left eye, right eye, left eye. Perfect. This examination is very important, namely in the acute phase of an acute vestibular syndrome, to look for a so-called vertical divergence, one eye above the other. If you were a 90-year-old patient with a stroke in the brainstem, you might have this skew deviation. If the doctor sees a skew deviation, this indicates most likely a brainstem infarction or cerebellar infarction, and you'd be immediately transferred to the hospital. But in your case, everything was fine. And now close your eyes. 1, 2, 3, 4, 5. Open your eyes. If someone like her is able to stand on one leg with the eyes closed for at least 5 seconds, you can be sure that, as expectant, your balance is perfect.